Fucosidosis is an autosomal recessive lysosomal storage disorder caused by defective alpha-L fucosidase activity, leading to the accumulation of fucus containing glycolipids and glycoproteins in various tissues. Become engorged with undigested substrates, which leads to secondary storage defects affecting other metabolic pathways. The enzyme is a homotetramer of approximately 50 to 60 kilodaltons that hydrolyzes fucosyl bonds by acting on natural oligosaccharides and glycosphingolipid substrates resulting from changes in glycosylation and proteolytic processing. Fucosidosis is a rare disease with an estimated prevalence of 1 to 200,000 live births worldwide, with cases reported in Japan, Western Europe, Cuba, and Italy. Fucose is a deoxysugar found in most plasma glycoproteins and in tissues mucopolysaccharides and mucolipids. Fucose originates from the Latin word fucus, meaning seaweed or red paint, and the suffix "ose" is conventionally used for the carbohydrates and sugars. The sugar was first isolated from brown algae, which are known for their reddish color. Fucosidosis is named according to the non-hydrolysable sugar, and both fucosylated glycolipids and fucosylated glycoproteins are stored in the lysosomes. Fucose-linked glycoconjugates negatively affect the activity of hydrolases by changing the substrate binding properties of other hydrolases in the lysosomes, or by affecting the stability of the enzymes. Therefore, in order for fucose-linked glycoconjugates to be separated into their monomers, fucose must first be removed. This dysregularity in lysosomes triggers oxidative stress, cell damage, and the subsequent onset of an inflammatory response. Dysfunction seen in lysosomes can lead to cell death, especially in microglia, known as the protective cell of the brain, contain a large number of lysosomes in their cytoplasm. This dysfunction in lysosomes, which can cause cell death, greatly affects the central nervous system function. Fucosidosis is divided in two types according to the age of onset and clinical features. However, since fucosidosis is a rare disease, the diagnosis of patients described so far has been delayed and the clinical findings have varied. And the current view is that the severity of the clinical disorder is a single disorder with a wide range of symptoms rather than two distinct types. Historically, clinical symptoms of type 1 fucosidosis begin early, approximately 6 months of age. Neurological deterioration progresses rapidly, and patients usually die between the age of 5 and 10. Affected individuals exhibit profound psychomotor retardation, seizures, coarse facial features, hepatosplenomegaly, skeletal abnormalities, and significant neurological deterioration. Type 2 progresses more slowly, and therefore symptoms appear before the age of 2. Although patients rarely survive to the age of 30, they usually die in the second decade of life. The slower progression of neurological deterioration and the milder course of the disease have been considered features that distinguish it from type 1. Psychomotor retardation is present but less severe. Seizures are less frequent, and the coarse facial and skeletal features are milder. Neurological symptoms progress more slowly, allowing for some retention of motor and cognitive function. Clinical manifestations and long-term outcomes in adults. Fucosidosis causes serious deterioration in mental and motor function. In addition to neurological disorders such as a difficulty in standing, loss of walking ability or frequent falls, acquired virus deformity in the feet, difficulty sitting and deterioration in language skills, patients are also described with flexion contractures, spastic quadrilateral paralysis with increased tendon reflexes. In rare cases, permanent incontinence, epileptic seizures, or asymmetric mild to moderate sensory neural hearing loss and Eustachian tube dysfunction can be observed. In the neuroimaging results of the patients, changes in white matter and gray matter were identified. In particular, the prominent white matter abnormalities of the globus pallidus in fucosidosis are considered to be specific findings for this condition, helping to distinguish it from other neurometabolic disorders. Along with a wide nasal bridge, an abnormal distance between the normally symmetrical paired organs known as hyperthyroidism is seen in this condition. In cases of malformations, the increase in height and weight stops after certain age and growth retardation is observed. And in our adults, at the last follow-up, their height was at the almost 3rd centile and 6th centile accordingly. In terms of respiratory and airway disease, patients present with recurrent infections, emphysema, sleep apnea, change in their voice, a loss of smell. The airway disease has been described in some cases as bulky subglottitis, large tongue, diffusely enlarged bilateral tonsils, causing severe narrowing of the oropharynx. The adenoids are also grossly enlarged with severe narrowing of the nasopharynx and partial obliteration of the nasal cornea. Cardiac complications are not very common. Cardiomyopathy has, however, been previously described, and cardiorespiratory complications are the main cause of death. Hence, these patients require a close surveillance of the ENT specialist during the perioperative assessment. Skeletal abnormalities are one of the commonest pathognomonic features of the condition. Cervical platysmal noduli, wide ribs, deformities, scoliosis, hump and back deformity of the lumbar vertebra, and short odontoid processes have been described. And this X-ray presents dysostosis multiplex in our 31-year-old patient. Dysostosis multiplex is a term describing the characteristic skeletal abnormalities seen in mucopolysaccharidosis and related diseases. And these abnormalities include a range of changes in the shape of the bone and structure, such as thickened ribs and flared iliac bones and bullet-shaped bones in the hands and feet. Ophthalmic manifestations are common but not specific for this condition. Accumulation of storage material in conjunctival, retinal, and skin vessels, mild clouding of the corneas, strabismus, and conjunctive papuloedema have been observed. And it's been shown that this storage material accumulates in conjunctiva, in the vessels, in the retina. In addition, histological evaluation of conjunctival endothelial cells revealed clear vacuoles with reticular structures similar to those seen in mucopolysaccharidosis and dark inclusions with dense granular material. Mild cornea clouding, strabismus, congestive papuloedema have been reported in some cases. The fact that angiokeratomas usually occur with age and that type 2 patients are more likely to survive into adulthood has led to the symptoms of angiokeratomas being suggestive of type 2. Angiokeratoma corporis diffusum, telangiectasias, skin thickness, acrocyanosis, hyper and hypohidrosis, and transverse nail bands have been described before. Skin lesions are usually seen as red or purple raised dots on the lower abdomen and genital area, but also on the upper and lower limbs, like in our patient. Angiokeratoma corporis diffusum is more likely to be seen on the skin depending on age, and although not pathognomonic, it raises suspicion of the diagnosis of fucosidosis. Angiokeratomas, which cover the whole body, are punctate deposits of capillaries within the papillary dermis. Angiokeratomas are more likely to be seen in patients of 20 years of age than in patients under the age of 10. And the cause of this skin abnormality is not clear, but one of the hypotheses is that undegradable glycolipids and glycoproteins accumulate in endothelial cells, leading to apoptosis of these cells and subsequent regeneration of these cells, resulting in capillaries. Telangiectasias are known as permanent capillary dilatations, and some patients have only telangiectasias with no angiokeratomas. While the systematic burden of fucosidosis and other glycoproteinosis is well recognized, endocrine complications remain poorly characterized and are likely underdiagnosed in adult population with these conditions. Emerging evidence suggests that hormonal dysfunction, particularly involving the gonadal and thyroid axis, may contribute to morbidity in lysosomal disorders. And despite this, routine endocrine monitoring is not consistently implemented in clinical care. This study investigates the prevalence, type, and clinical relevance of endocrine abnormalities in our adult cohort of patients with glycoproteinosis, including fucosidosis, with the goal of supporting more integrated long-term management strategies for these patients. This study highlights a significant burden of endocrine dysfunction among adults with fucosidosis and other glycoproteinosis, with nearly half of the patients affected. Hypogonadotrophic hypogonadism was the most common finding, characterized by low gonadotropins and reduced sex steroids, suggesting possible disruption of the hypothalamic and pituitary axis. Similar patterns have been observed in other lysosomal storage disorders, where lysosomal accumulation may interfere with central hormone regulation as well as peripheral gland function. Thyroid function, although less prevalent, further supports the need for multi-axis endocrine assessment in this group of patients. So, in summary, life expectancy of patients with fucosidosis type 2 can be normal, while neurodevelopmental and dysmorphic features are common at diagnosis. They remain stable over time, and psychosis can be a feature of fucosidosis as well as other oligosaccharidoses. Skin, eye, respiratory, airway disease require close surveillance. Organomegaly and cardiac complications are not very common in adult patients with fucosidosis. Secondary endocrine dysfunction is an underestimated complication of fucosidosis.
Okay, well, we don't have the opportunity to thank Dr. Stepien directly, but she's given us beautiful summaries of a number of diseases so far, including fucosidosis. And at this point, since we're not able to ask her questions, I think we should move on to the next talk, which is again from our colleague, Dr. Troy Lund, who's going to speak to us about hematopoietic stem cell transplantation for fucosidosis. Welcome back, Troy.
Thank you. All right.
Dr. Desnick, for those online, pointed out he has never seen angiokeratomas like that in the very large number of patients he's seen. Okay. Like another dermatologist. No. No, it's not that dramatic in Fabry, that's for sure, for sure. Yes, no, I agree. That I was looking at that thinking that's very dramatic. Very, very dramatic. You may well be right, Bob. All right.
Probably. All right. So transplants. So again, we'll be limited by numbers of patients that we can talk about, but at least we've seen a few for this. Click. Is the clicker still clicking or not clicking? You do the, okay. Good. You do the first one. So autosomal recessive disease, males and females, 100 cases in literature. We've talked about the enzyme. We've talked about doesn't digest fucose. So, and you get accumulation of substrate material like in all the other diseases. You have different presentations. In this case, presentations based on residual activity. So type 1 is usually having no activity, and then after infancy, it's type 2 disease. You have a little bit. Talked about the clinical symptoms, angiokeratomas, which in the patients that I've treated here also aren't that extensive as what was shown on the screen. So that was remarkable. They have skeletal problems, of course, facial features, neurologic deterioration, seizures, hypotonia, organomegaly, hearing issues, recurrent respiratory infections. We believe that's a quasi-immune deficiency that these patients have, and kyphoscoliosis. So historically, the diagnosis and management through clinical signs and symptoms, developmental history, urine for oligosaccharides, the radiologic findings that we've talked about, including in this case, the globus pallidus is a key area of the brain that is affected by this disease, and then enzyme activity and genetic testing. I don't need to show this slide because I already showed it. Bone marrow transplant, and this is stem cell therapy, and the potency of the marrow, and the blood-brain barrier. So this was much better when it was one talk on all 7 diseases. So, but now I have to do the same slides. So what do we know about transplant? Very, very little. There are a few papers describing transplant in the disease going back to 1995. It certainly can alter the substrate buildup. It can restore peripheral blood enzyme, obviously. It may affect MRI findings as well. There are these cases of transplants reported, plus I think we have 4 now, at least 4 patients we've transplanted, 2 of them quite recently at the University of Minnesota. And when I mean recently, I mean within 5 to 7 years. So these are the patients previously described in the literature who underwent transplant, the year of the publication, and who reported it. You can see the presentation of the patient given there with the abnormalities in MRI and then all the other findings. Age of transplant was relatively early for 2 of them, age 3 for the third one. Some of the GVH complications are listed there. Enzyme levels are normal in everybody's lymphocytes, as you'd expect. And then some of the outcomes. So mild developmental delay for patient 1, better than the older sibling. You'll see that time and time again. Improved MRI, that's a consistent thing we've also observed as well. And then a third case report says no progression of neurologic deterioration, growth improved hematosplenomegaly. So, and we'll see if that holds up as well. So those are the 3 that were previously published. So here are 4 kiddos. And this time we have the mutations there listed for those that are interested. The age of presentation, 5, 4, 7 months, and 18 months. So 2 up top there are relatively later. The underlying issues at transplant. So developmental delay is a common feature. Hypotonia as well. Where's the MRI? I think one of them had an MRI that had the globus pallidus findings. They all seem to have some degree of immune deficiency. They're low IgG levels, like in patient 2 there, or they have pulmonary infections, recurrent pulmonary infections. Let's see here. So then how do they do after transplant? Well, I can say third patient's deceased. So they had a alveolar hemorrhage, so it's a bleed in the lungs, and passed away. Other patients are alive. Now, this is actually, you can add 2 years to all the transplant follow-up, but they're surviving. The transplant complications are given there. There was one patient with graft failure, then did okay after the second transplant. And then on the outcomes, we note that in all these patients, their respiratory status is remarkably better. Whatever that immune deficiency was, whatever is going on, their lungs is completely solved. After day 100, practically speaking, they never have pneumonia again in their life. Biochemically, they all have low enzymes pre-transplant, and after transplant, of course, they're normal in the white cells because they're from the donor. So that's great. And then for the ones we had measurements on, urine oligosaccharides are given at 6 months and 1 year. So normal for these guys. So it looks like we can normalize urine oligosaccharides in at least 3 of the patients that I've talked about. Is there really slowing of imaging progressions? Always a soft call when you're trying to look at imaging over years in the developing brain. And so this patient had some white matter disease here frontally, as you can see. There's also some posteriorly as well. 4 years post-transplant, we'd like to convince ourselves that this level of disease is discordant from natural history. That is, this patient has progressed slower than she would have otherwise progressed. At least that's what we'd like to think. There might be some atrophy at 4 years post-transplant, but not as much as some of the other diseases. Another kiddo we saw pre-transplant and then post-transplant, again, white matter disease here posteriorly, pre-transplant. Post-transplant, we'd like to convince ourselves it's maybe a tiny bit better. You really have to stare hard at it, and you could say, well, yeah, maybe it's less extensive. But, these are the things that we constantly look for as something positive about the effect of transplant. And is there any atrophy? It's not entirely clear. There's some ventricular enlargement here in the post-transplant setting, but overall, this is kind of a consistent feature time and time again when you read about the case reports, is that maybe the imaging abnormalities are a bit better. So what is the supportive therapy for all these kids? They're all in speech, physical therapy, occupational therapy, some are in music and aquatic therapy. Walking is a challenge for these children. Some of them walk very unstable. Some of them are able to scoot and crawl as toddlers. They still use wheelchairs for long distances, for sure, because of the instability in walking. Cognitively, it's a really tough road for these kiddos. They're not communicating with words that at all. So they're mostly nonverbal. They are using, they can follow some simple commands. Some of them know some signs. They do seem to demonstrate their needs through signs, sometimes through some utterance, and sometimes through an iPad. At least that's what I've seen. So they can communicate needs, which is important to the families. But it's pretty difficult to even get these kids tested. They working up to using augmented therapy for expressive language, nutrition by mouth, no swallowing issues. One of the kids has like a G tube for medicines. So I don't want to kind of paint such a rosy picture that these kids are all doing great in mainstream school, because that's not at all the truth. They're really challenged in terms of their gross motor, and they're really challenged in terms of their cognition. So the discussion conclusion, kind of putting it all together, there may be some stabilization of neurologic progression And then the caveat, again, their function might be quite low pre and post-transplant. There may be some stabilization, improvement in growth. There's biochemical evidence for normal enzyme in the blood for sure. Parents report improvement in motor and communication skills. I don't know how objective we've been about that. I'm just thinking about the kids in my mind and anecdotally telling you about them. And the ones that Julia's tested, you could probably hear from her what she thinks about it. There may be evidence of disease stabilization, but it's not as consistent as I would like. For sure, the pulmonary disease is better. That's the one thing I'm absolutely convinced about. What does the future look like? Gene therapy, perhaps, gene addition, or what people call as gene editing, where you change the gene, but gene editing is far from the future, given how efficient it is. You could maybe do it in your own cells, but again, you can't correct many of the cells. Enzyme therapy, every now and again, a company might get interested in enzyme therapy. I don't know who's in the game right now and where they're at. It's often limited by cost, not enough patients in the blood-brain barrier. Maybe enzyme with transplant would be a good option in the future. What about alternative therapies like injection of healthy glia? I bring this up because this is becoming more and more of a strategy. It's called microglia replacement, and companies are looking at it for some of the microgliopathies that I see in the leukodystrophy field. And so that may be a reality someday. It's currently at its infancy, but the data looks really good in some rare diseases. It's limited by procedure and cell number. And so that's it for fucosidosis.
Thank you again, Troy. Do we have any questions online or in the room for Dr. Lund? Nothing at the moment. Well, if that's the case, we can. Oh, Dr. Whitley, were you going to ask a question? Sure. Go ahead.
Of course he is.
Yeah, Troy, I know you're being very conservative in your observations, but I wonder, and you do spinal taps frequently. If you do them under a standardized method, you can detect if they have marginally or frankly elevated CSF pressure. That went down with all the kids with Hurler syndrome. You're also doing a lot of chemistry in the CSF. You know, the Sanfilippo A enzyme that Ultragenyx is doing is probably going to get approval based on that alone. Anything about that?
Oh, interesting. Yeah, we have stored samples, but honestly, we never really analyzed them. They're sitting in a box for most of these kids because there's just not enough of them there to. I'm worried about the cost of analysis, and then what do you do with 4? And I don't have controls, but they are available. I mean, it's good at these meetings to stand up and say that, because maybe somebody else says, well, I have 4 samples too, and they've not been treated. And then together we could do it and make meaningful data out of it.
I just checked my pocket. I don't have 4, but you know, there's also other natural history study data. Not that's tough, but there are a lot of patients maybe that did not get treated that are still around. Natural history study, compare them to these, you know, I think it looks really good. If you had only pulmonary function testing as your outcome measure, you've got a drug that's approved.
Yeah.
You've showed improvement.
Yeah.
From time, it's an N of 1 study on each one of the 4, right? So
Yeah.
bad, good, that's a therapy.
Yeah, for sure. Yeah, PFTs are very, very much better.
Thank you again, Dr. Lund. Thank you, Dr. Whitley, for those excellent questions. So our next speaker is it Matthias Schmidt next, or are you speaking next? It's Matthias. I think Dr. Schmidt is speaking next on evaluation of the effects of JR 471. Dr. Schmidt is from JCR Pharmaceuticals. He's going to talk to us about targeted enzyme replacement therapy. So it answers one of the questions that Dr. Lund just asked. He appears to have an antibody with him there as well.
Yes, I do. It's my best buddy. I thought I would speaking after Carolyn, but okay. Anyway, Abby kindly allowed me to change the order of my slides. And I thought I want to start with the end. First, please read this. This is very important and very interesting. Don't believe anything that I'm saying. So I don't have a clicker. If somebody can click for me. So I said I want to start with the end. And I'm standing here totally undeserved because I want to convey the experimental results of a wonderful research team at JCR who was working on something that we mentioned this a few times, the JBrain cargo platform technology. We all want to bring the enzyme into the brain, and they have accomplished something that it's not science fiction, it's real science, and it does make a difference. What Chad kindly also mentioned is, how difficult it is actually to raise funds for an ultra rare disease. It's very, very questionable whether we make any dime on a therapy that only treats so few patients. And this would not have been possible if there's also other companies who support the work of JCR Pharmaceuticals. In this case, it is Medipal, a Japanese company who is also, in full disclosure, a shareholder of JCR, but we are immensely grateful to Medipal for their support. What I've not listed is actually Carolyn and the patient groups, because this all started when Takayo Egawa, who's also in the room, connected with Carolyn and to say, look, we want to hear more. We want to learn something about fucosidosis. Can you connect us with families? And we had 2 web sessions, and that was all the start. And I remember one mother who said, Matthias, don't play with our emotions. There's no way that you're ever going to develop a disease for fucosidosis because it makes no sense. And I responded, you're absolutely right. But we want to listen, we want to understand the disease because we cannot develop anything without understanding the disease. But we are not here to give any false promises saying, we are going to embark on a development. But I'm just most grateful to the support that we received that we can proceed with this program. So everybody knows about enzyme replacement therapy and the limitations. We can't get it into the brain. And this is where this technology kicks in. And I want to sensitize you a little bit how difficult it is to get those proteins into the brain and why it is. So everybody's talking about the blood-brain barrier. And here is a picture of the blood-brain barrier. So on the left side, for those ones who are online, it's basically a micrograph of the vasculature in the brain. And it's the best vascularized organ. But the downside is, if you look on the right side, if you take a cross section and if you look through it, it is super, super, super tight. And it's meant to be super tight because the Mother Nature does not want any infectious or noxious agents get into the brain. But we need to find a technology, a way how to get here from the lumen into the brain. And many people have tried. We need a road into the brain. It's slightly more complicated than, putting an antibody on a skateboard and getting it into the brain. So people have tried many things. One of this was injection directly into the brain. And what you see on the right side, if you look, what is the dilution and the diffusion? So if you start with 100,000 units, nanogram per gram, and for each millimeter that you diffuse, the dilution is by 1 order of magnitude. So our brain is diffusion limited. So we would have to have hundreds to thousands of injections into the brain in order to have a meaningful delivery. And this is not possible. And if we inject it into the cerebrospinal fluid, we only surround it. It's better, but we only surround the brain. People also have tried a reservoir where it goes into the ventricle, and they try to inject the enzyme replacement therapy into this device. It's getting closer, but it's still surrounding the brain. And one enzyme replacement therapy, Brineura, for Batten's type 2 has been approved. It's a game changer for those patients. However, what you can see in the natural history, if people are, individuals are on the ERT, they're still progressing because it just doesn't go into the deep brain regions. So the best way to do to get things into the brain is actually IV via the vascular bed that surrounds, that is in the brain. But if we do this, like, we see here on the left side, we need something that can, let those enzyme replacement therapies cross the blood-brain barrier. And here's where this technology kicks in. So Mother Nature brings large molecules into the brain by a mechanism called receptor-mediated transcytosis. A ligand binds the receptor and the receptor shuttles it in. And JCR has done basically what Mother Nature has invented. So they have made an antibody. And this antibody binds to this receptor and it gets transcytosed into the brain. And the antibody is therapeutically totally inert. It's nothing but, a rocket that goes into the CNS orbit. But what we can do is we can genetically fuse the enzyme that is missing in fucosidosis and in other diseases, and then bring the antibody and the enzyme into the brain. Now, this really sounds like science fiction. Well, it is rocket science, of course, but sounds like science fiction. But the first molecule actually for a different disease, MPS II, has been approved more than 4 years ago and is actually marketed in Japan only. So we try to apply this to fucosidosis. And this is only an example of the, sorry, I hit your head. It's only an example of the molecule. It looks slightly different, but it's an antibody fragment. We fuse the enzyme to it, and then we tested it. How does it look like? So very boring slide. We first look, do we have any kind of tissue exposure? Please only look on the right side, CNS exposure. And the open figures, circles and squares, this is actually different doses of the fusion protein. But, you might say, Matthias, where's the naked enzyme fucosidase, which is the closed boxes and circles, and it's not there because it doesn't cross the blood-brain barrier. But it's also seen, in the plasma, the half-life is the same, and in peripheral tissues, we have a similar uptake like the normal enzyme. So the antibody does help very little in the peripheral organs. Now, we also looked into the brain. Do we see it actually in neuronal cells? To cut the whole story so short, this is immunohistochemistry. The brown spots that you see is actually the detection of the enzyme in certain neuronal cells. So what you can really see very nicely, it's not only going into the brain, but it's really ending up in the neuronal cells, in the Purkinje cells in the brain. We next did a analysis in fucosidosis mice. So these mice have the enzyme knocked out. They have the human transferrin receptor knocked in because this is where the antibody binds. And then we look, how does the substrate actually look in various different tissues and organs? For those ones online, let me start actually on the right, on the bottom, middle and bottom. If we look at peripheral organs like the heart, the liver, kidney, and spleen, here you see the wild-type animals. They have hardly any detectable levels of substrate. This is the diseased animals, a lot of substrate. And if we come in with the enzyme replacement therapy, various different doses, we see a beautiful clearance in all the peripheral organs. Well, not so surprising because enzyme. But if we look into the brain, into the cerebrospinal fluid, spinal cord, these are the sanctuary organs for the unconjugated enzyme, where we see, basically no clearance of the substrate. And we see a beautiful clearance here, also in the central nervous organs, which is actually the hypothesis that we started out with. We were very happy to see these results. The scientists at JCR were very adamant about me showing this slide as well, that we have a very nice correlation between substrate reduction in the brain and in the CSF, being an indicator that the reduction of the substrate in the CSF might serve as a kind of a surrogate biomarker for the efficacy also in human beings. We also see not only the reduction of the substrate in the brain, but we also see changes, pathological changes. So if you look at the the H&E staining on the top, what you see is a lot of vacuolation in the diseased animals, which is kind of mitigated and abrogated at low and high doses of the fusion protein. What you also see is enlarged lysosomes, which can be detected with LAMP1 staining. And we see this a lot in the diseased animals, and we see that this is corrected upon treatment with the antibody enzyme fusion protein, as much as the loss of Purkinje cells, which is shown on the bottom. We can also prevent the loss of the Purkinje cells in this animal model of fucosidosis. How do we measure a functional outcome like the FDA wants this? And I'm somewhat serious here, because when we validate a biomarker, when we validate in a disease model, they also want to see a functional outcome in animals. And sometimes, like in beta monoacidosis, this can be difficult. So we put those animals on a rod, and then we start spinning the rod, and we just measure the time until they fall off. And this is what you see here is, this is how the normal animals behave. There's always some stupid guys who fall off quickly. But here's the disease control, significantly different. And if we treat them, we have a very significant correction as well. And there's also an active avoidance test where they can, upon stimulus, they rush into a kind of different compartment. And here we have also a very nice correction in the animals that are treated, but not here. This is what we see with the black is the untreated animals. Basically, we believe that this molecule might have legs to go forward into the clinic. I really want to encourage you, stop by at this roll-up banner. So Medipal and JCR have teamed up, and we're trying to use cautious language. We are trying to fulfill some of their wishes. Carolyn very kindly helped us, asking the families, what were your wishes if there was a therapy available? And I personally found it very, very touching to see what wishes they have. They're very, very humble. But if we all believe that all life created on this planet is equal, regardless of how many stars we have on our shoulders, those individuals like beta monoacidosis, like all the other ultra-rare diseases we heard today, they deserve the same love and attention like anybody else here in the room. And that's what we're working for. Thank you so much.
Matthias, thank you for sharing that exciting work. Comments from the audience or questions? Can we get a microphone for Dr. Desnik?
I know you've done this with MPS II, and it's worked very well. My question is about the enzyme. Some enzymes are much more stable than others at 37 degrees. How do these different enzymes work in terms of stability in the brain? And do you know the difference between the stabilities of the different enzymes that you're looking at?
Yeah, this is a fantastic question. And the question behind your question is, can we apply this to any kind of enzyme and cure all LSDs? So in all honesty, this looks like plug and play, but it looks like plug and play, but it is a lot more complex. In some diseases, it works remarkably well. MPS I, MPS II, very stable enzymes. The therapeutic also has a shelf life that is very, very long. And the enzymes, they're actually made, they live in the lysosome. And the lysosome is probably the harshest environment where we can live. Full of proteases, low pH, just the most terrible environment to live in. It's like, the Death Valley of, of the cell. And they survive there. And we believe that the stability of the enzyme is long enough, to have like weekly or fortnightly treatments. We never really push it to a boundary. Can we do it every 3 weeks, every 4 weeks? That is something to be figured out.
Have you ever cross-linked any of these enzymes to increase the stability?
Cross-link the enzymes. to
So-
increase like with albumin or
No. There are certain cross linkers that are used in protein chemistry where you can take and actually lock it up a little bit.
Yeah.
And as long as you don't interfere with the active site, you're in
Yeah.
good shape.
good point. We haven't.
I'll
Yeah.
patent that.
We haven't. Yeah. But good point.
Yeah. My question is really related to what Bob just said. That is, how are you attaching the enzyme to the antibody? Is it a biochemical linkage, or are you doing it as expressing it as a fusion protein?
Yeah. So we express them as fusion proteins, and we do it like everybody else in CHO cells. These are, for those ones who are not familiar with it, it's basically the ovaries of a Chinese hamster that died decades ago of ovarian cancer. And this Chinese hamster was kind enough to dedicate her ovarian cancer cells for us to manufacture antibodies. Almost all antibodies on the market are made actually in those CHO cells.
Yeah. So you make the fusion protein, express it and show
Yes.
that. That's fine. How large is the total coding sequence of that?
So the number of amino acids, I don't know out of the top of my heart, but the
nucleic acids.
so the molecular weight of the largest molecule that we have is unglycosylated 290 kilodaltons. So this is huge.
Yeah.
And we have expanded this into gene therapy and those adeno-associated viruses. I mean, it works incredibly well, and they're even larger. So we don't really believe that there's a size limit.
But there's a size limit to adeno-associated virus.
Yes,
So-
of course,
so
what you
that's
can
okay.
pack in as a transgene.
You
Yes.
can. Okay.
Yeah, there's a limit.
Yes, that was a wonderful presentation. My question pertains to the transferrin antibody that we're using to target the blood-brain barrier. Is there something special about the transferrin? Are there other molecules that could be just as good?
So, wow, very good question, Virginia. So there is other receptors suitable, like there's a lot of clinical evidence with the insulin receptor. You could use LRP1 leptin receptor, IGF-1 receptor. The transferrin receptor technology is actually the most advanced clinically. It's always a matter, how safe can you be? With the insulin receptor, nobody really believed you can do it because you would interfere with glucose homeostasis, but it is totally possible. And with the transferrin receptor, there's always a certain risk that you induce anemia because the transferrin receptor is also in large amounts in the bone marrow. But with the JCR molecules, it never really has risen up as a clinical risk factor. I mean, it's like I can never say never that this will never ever happen, but it was not like that this was something that was raising major concerns.
Well, again, thank you. It was a fabulous and exciting talk. Much appreciated. Now I'd like to call on Carolyn Paisley-Dew, who's the president of ISMRD and one of the organizers of this meeting, who's come a long way to talk to us, to speak to the patient voice, specifically unmet medical need in fucosidosis. Carolyn, welcome back.
Thank you very much, Mark. That's a very hard act to follow. It's just me now. So, yes, I've been on the ISMRD board since 2006 and have been president for the past 4 years. If I could have the first slide, or can I do the first slide? So, second slide. This is my son, Matthew, when he was 2. He was diagnosed with fucosidosis and passed away when he was 10. I'm here as a parent and advocate for children with rare diseases, and my objective is to outline our family's experience with fucosidosis and describe the disease's impact and emphasise the ongoing need for research, awareness and support. We've heard from Carolina Stepien what causes fucosidosis. Symptoms often include neurological deterioration, intellectual disability, seizures, skeletal abnormalities, angiokeratoma, as we've heard a lot about, and recurrent respiratory infections, the disease typically results in a gradual decline in a child's abilities. Fucosidosis also exhibits significant variability. For instance, could I have the next slide, please? This is Susan. She's Turkish. She's 58 years old now, and she has fucosidosis. We know of a child who passed away at 16 months from fucosidosis. Siblings Lauren and Stephen present very differently. Stephen, 31, experiences, oh, sorry, can I have the next slide, please? Next slide. Oh, ultimate power. Sorry, Stephen experiences joint stiffness and reduced stamina, impacting his mobility, and he has a susceptibility to illness, though he can perform limited work. Lauren, his sister's 26. She has greater stamina and recovers quickly from minor illnesses, but has cognitive impairments. She also has angiokeratomas, and you can see those there. They're on her arms and her legs. You might recognise them. She is one of Carolina's patients, so we saw her earlier. So this variability highlights the disease's complexity and the need for further understanding. Due to its rarity, many medical professionals are unfamiliar with fucosidosis, frequently leading to delayed diagnoses. Currently, there is no known cure. Early research on Springer Spaniel dogs with fucosidosis indicated that bone marrow transplants might be effective if performed at a very young age. Christopher in England received a bone marrow transplant at 11 months of age after his older brother was diagnosed with fucosidosis. He's now 34, lives in a group home, has some speech and uses a wheelchair. Dr. Lund has told us about his work with bone marrow transplants in older children with fucosidosis. And as we know, JCR Pharmaceuticals is developing a blood-brain barrier penetrating enzyme replacement therapy for fucosidosis, which is an absolutely amazing development for such a rare disease. For our family, Matthew's initial signs appeared around 18 months of age. Concerns about his walking and talking milestones were raised during routine checkups. He later stopped crawling. An initial assessment for arm injury yielded no findings, and cerebral palsy was considered. However, a physiotherapist observed movement patterns inconsistent with cerebral palsy, leading to suspicion of a more serious condition. A paediatric neurologist who monthly visited Canberra, where we live in Australia, examined Matthew and suspected a degenerative disease, such as metachromatic leukodystrophy. Matthew and I subsequently travelled to Sydney for a week of diagnostic testing. We received the fucosidosis diagnosis. Sorry, it's really hard going back 19 years and reliving all this. We received the fucosidosis diagnosis when Matthew was 2 years old. This diagnosis was provided within 6 months, which is much more quickly than many families experience. Over the next 8 years, Matthew's condition deteriorated. He experienced loss of speech and mobility, inability to eat independently, meaning a G-tube, difficulty regulating body temperature, development of epilepsy, asthma and esophageal reflux, osteoporosis and dislocated hips, a condition similar to quadriplegic cerebral palsy, recurring ear and lung infections, 43 hospitalizations in 8 years. Ultimately, he passed away from double pneumonia at age 10. Most deceased fucosidosis patients I know of have passed away due to pneumonia. So obviously what Dr. Lundis told us about bone marrow transplants for fucosidosis is very important. You know, if you want to prolong life and if you can prevent pneumonia, you're going to do that, even if it's just while you're waiting for some treatment or cure to come about. Now, during those 8 years, our home environment adapted to Matthew's medical needs. His siblings also experienced the challenges associated with his illness. Despite his limitations, Matthew connected with people. He had an enchanting smile and caring nature. His funeral service highlighted the positive impact he had on others. He had demonstrated resilience and an ability to find joy in everyday experiences. We focused on providing him with care and support. So beyond the medical aspects, fucosidosis presents significant challenges. The emotional burden. Parents and siblings face continuous grief, fear, and sadness. The grief starts with diagnosis, not just at death. Financial strain for specialised care equipment, medications, loss of income all contribute to substantial financial pressure. Social isolation, the rarity of the condition leads to this. Others don't comprehend the experience of caring for a child with a rare, progressive and terminal illness. In Australia, Matthew remains one of only 2 individuals diagnosed with fucosidosis in 27 years. This is one of the reasons I joined the board. I joined after he'd passed away because I was too busy looking after him before that, because I wanted to try and prevent other families going through what we went through. There's also limited awareness and research. Low awareness of rare diseases often results in limited research funding and fewer treatment options. Matthew's life, though brief, underscored the need for collective action. We can take the following steps. For researchers in the medical community, increased dedicated research is needed to understand fucosidosis, develop effective therapies, and identify a cure. Improved diagnostic tools and protocols are also essential for timely intervention. For policymakers and advocates, develop and implement policies that support families caring for children with rare diseases, ensuring access to necessary medical care and comprehensive support services. For everyone, promote great awareness of rare diseases, share information and support organisations dedicated to research and finding cures. Every conversation, donation and advocacy effort contributes to a future where families are better equipped to manage fucosidosis. Matthew's legacy fuels our ongoing efforts. By working together, we can strive to prevent other families from enduring similar challenges and contribute to a healthier future for children affected by fucosidosis. Let me now talk a little about ISMRD's Unmet Patient Needs Survey and its results for fucosidosis. If I could have the next, I'll do it. Right. I forgot about. So, the most common symptoms, developmental delay, neurological decline, and organ dysfunction basically mean my child can't communicate. Matthew couldn't talk or even sign because his hands were clawed. Neurological decline, can't walk, mobility issues. And organ dysfunction is primarily your ear and lung infections. So those are the 3 main things: communication, mobility, and infections. The desire for improvement was very similar. Walking and talking, but also access to care and health system improvements were important to families. The burden of disease. For patients, physical limitation and pain. You have to understand there that that is the patients that can communicate. If you could ask the ones that can't communicate, they might say walking and talking. It's my biggest burden. Not walking and talking are my biggest burden. For the caregivers, emotional impact, and the same for siblings, the emotional impact. 2 more. And that's the biggest obstacle for families, is the lack of treatment options, almost overwhelmingly. So that's Matthew at 9. The year before, it's his birthday party. We had a superheroes party. That was the year before he died. So thank you very much.
Thank you, Carolyn. As I said before, I think it's living the experience is difficult, but standing up in front of a group of people is also very challenging. So thank you for your courage in doing that and all the work you've done together with the other members of the ISMRD. It's tremendously important to advance the field, and I think this meeting and others like it is a great product of that. So we've reached the point again where we invite Dr. Janis back up to talk about outcome measures for fucosidosis.
Were there any questions for Carolyn or Matthias Schmidt that came in? I guess I should ask, or we already checked that, right? Dr. Patterson already checked that. So looking at fucosidosis, it seems right now we're pretty confident there's two phenotypes. Is that what everybody's sort of in agreement with? Okay. And there's one retrospective study that I think qualifies as a nice natural history study. However, it was done in 1991, but they went back and looked at case reports on 77 patients and an international questionnaire survey. So a combination of the two. And in that study, it involved patients that were very young and then some that were well into their adulthood. And they found that mortality before age 5 years was 9% of the patients had mortality before the age of 5. And I think we're considering that the type 1 fucosidosis. 36% or 64% reached the second decade of life. And I think that I just want to make a comment here on phenotypes. And Dr. Whitley brought this up a little bit. There's a couple schools of thoughts that I keep hearing. One is we have to establish the phenotype and define it. And then there's other research projects that come out with the conclusion that this is a continuum and we can't really establish a phenotype. It kind of is a continuum. But I would like to speak in favor of establishing phenotypes if we can see some kind of, even if they're rough around the edges, because for clinical trial design, it's helpful to say, you know, a large subset of these patients have these specific symptoms within this age range, maybe not all of them, but we can see this, at least this subset. And then it helps us define things to measure that are predictable for clinical trial. So I just wanted to raise that point because it's come up in some of the literature I've reviewed recently and manuscripts that I've reviewed. So if we have type 1, most of these patients dying by the age of 5, or many of them, I would like to find the audience opinion on, would it be too simplistic to look at as an outcome measure the conventional primary care pediatric developmental milestones that are well documented for age 1 through 5 that would address motor skills and cognitive skills and speech skills? What are the thoughts on that? We do know that some of the companies that are doing clinical trials in the gangliosidosis, specifically Gemma Bio, is using some of these basic measurements from traditional old, conventional pediatric developmental milestones. Any thoughts on that? None? Bob Desnick, yeah.
And since you can't wait for survival, you've got to be able to look at the milestones. So I think that's a good idea. And I think you could sell that to the FDA. I think there have been some approvals that have been based on survival, but they take forever.
Right.
And nobody wants to collect data and see patients over 5 to 8 to 10 years. So, and of course, the real issue is early intervention. Mm-hmm. We all know how important that is. In every single lysosomal disease, in every single metabolic disease. The earlier you intervene, you can actually prevent some of these diseases. When you're making a late diagnosis, it's already
Too late.
maybe to the point of no return.
Right.
And that's happened with every disease that we look at. So the only thing that I can recommend overall is you've got to focus on newborn screening. That is the number one thing that once you don't know the incidence or the prevalence of these disorders. And I think until you start doing newborn screening and implement that in across the U.S. or whatever, there's a whole process you have to go through to qualify for it. And there's a group that decides on which ones will be done. And there's another group in Washington that develops tests that are easy to implement, to begin working with, and are useful. So I think that that's the next step. I mean, we need to know incidence and prevalence of these disorders, and that's what you learn from newborn screening. I think then you can really begin to look at intervention more effectively.
So, as you know, our criteria used to get a disease on the newborn screening panel requires that we have a treatment. So it's that creates problems, but we'd like to see that changed, right?
For the audience online, that Dr. Desnik was saying in response to Dr. Jonas' comment, that it goes two ways. The trouble is you really don't know the incidence or prevalence of a disease until you do newborn screening. But the catch-22 is if you use the old 1968 Wilson-Jungner criteria, which have typically been used by the RUSP and the other bodies that make recommendations about newborn screening, that you have to have a therapy that's been shown to influence the course of disease, which is simply not practical for these disorders. So one of the issues becomes, if you're going to do widespread newborn screening, how should you do it? There's no single biochemical test, of course, that will cover hundreds of biochemical diseases. So one approach, and again, this would be an entire meeting on its own, would be to do whole genome sequencing, which is being used in some places. That has challenges of its own as well. But I think the point is well taken.
I think one important thing would be, if industry is going to sponsor a particular, the development of a particular treatment, they should also help with the newborn screening. And maybe some states might be amenable to including it as a trial that is supported not by state or government money, but by industry. That would be something important to do. So I'm speaking to the different companies here that would be a good idea. And, you know, there are some places that have a higher incidence because of consanguinity, because most of these are recessive. I noticed there were some patients from Saudi Arabia. I once went to Saudi Arabia. I've been to Saudi Arabia 3 times, but the first time they said, "Would you like to see any patients?" I said, "I'd like to see Niemann-Pick A and B." 20 patients showed up one day. So I think there are ways of doing this, and you just have to be very thoughtful about how to move it forward. But until you know market size, no company's going to be interested. That's the first thing they asked me, I guess, 30 years ago when I first came up with the treatment for Fabry. And I pitched it to Big Pharma. I got 4 Dear Bob letters. You know, in the old days, it used to be Dear John, you know, and the girl would say bye-bye. Now they just text you or they forget to text you. But
Life has kept up with technology, Bob. That's
There
very
you go.
encouraging. Dr. Whitley has a comment to make as well.
What Bob hasn't says is he did that with Fabry disease in Italy. Was it Italy? Newborn screens?
On
30,000.
2006. Yeah, 2006.
2006,
Piedmont.
30,000 babies. And what was the actual incidence of Fabry disease? 10 or 20 times what people expected?
Yes. Yes. It was in consecutive newborn males. Yeah. Yeah.
it drops it down a little bit.
Yes, because
A
that
little
was, that was looking at mutations, but it was still a dramatic increase on the expected incidence pre-test, which was about 1 in 50,000.
And, you know, Italy is a good place to do that because they are interested in screening all the babies, and they just have to add another disease to their screening panel.
Yeah, so I'll just mention that the kind of model that Bob is talking about is supported by the NBSTRN in New York, part of New York rather, for Melissa Wasserstein's screening test for about 8 different diseases. So there's pilot studies. But Janine, you're on the board. Of course he is. But what do you think, Dr. Jarnes? Does it check all the boxes?
Which fucosidosis?
Yeah.
Well, it doesn't. It does not check all the boxes for the RUSP.
What boxes are you going to check, and how are you going to check them?
Well, you want a blood spot test that has high specificity and sensitivity, and a treatment that's FDA approved that shows efficacy, and a disease that can have extremely catastrophic consequences if it's not treated within the first year of life. So those are kind of the general RUSP rules. Not saying that I'm totally happy with that. I wish that wasn't the case, but that's what has limited us because they kind of conflict with each other.
Yep, a couple of things.
Would you like to stand close to the microphone, just for
Closer?
the online audience?
Can you hear me now? So a couple
Yes.
of things. I don't know what RUSC is, so I'm not going to talk about that.
Oh, recommended uniform screening panel
Okay,
at a government
yeah.
level in the US.
It's also been abolished
Yeah.
by the current government, so
Yeah.
we're in a little bit of limbo there.
There you are. So first of all, Fabry is very different from fucosidosis. As I understand it, if you find someone with Fabry disease and test their family, you will find a whole lot of family members with it. Fucosidosis, you won't find any. You might find carriers, but you won't find, so it's very different circumstance, but also getting back to outcome measures. The trick is diagnosing them. So, you know, it's very hard to diagnose someone with fucosidosis when they're young. It's only ever happened when an older sibling is diagnosed and the younger child is tested and found to have it. So how do we, you know, I like the idea of the milestones because that's exactly how my son was initially diagnosed, really. That's how it started, a diagnosis process. But you've got to know first before
I think
newborn screening.
Dr.
definitely.
Desnick was saying if we could have newborn screening,
Yeah,
then we could
sure.
move ahead so much more quickly on
Certainly,
all
but
matters.
for the moment, we do have to formulate outcome measures for the white paper, don't we?
Correct.
Yeah.
So,
At least
yeah.
we're actually at time,
Yeah.
but let's quickly run through some potential outcome measures. Then we'll let people have a regeneration
That
break.
was what-
Well, I wrote down kind of the low hanging fruit. Could we do fucose containing oligosaccharides in the urine and or the CSF? Thoughts on that?
I think, again, just to frame that, we want to think about potential primary and secondary outcome
Yeah.
measures. I think that in terms of biomarkers, measuring the specific oligosaccharides in the urine seems very appropriate.
Okay.
You know, one of the issues is, again, can we quantitate the findings on neuroimaging in these patients? I think that's probably possible. The challenge for that is the quantitative methods for neuroimaging do require statistical methods. And if you've only got half a dozen patients, that can be very difficult to do. It's not impossible. But then I guess the issue is, are there some clinical outcome measures we might use specifically for the early onset group and then for the more attenuated group? Dr. Desnick was suggesting developmental milestones are one of the checklists as appropriate to say, is this patient behind? Are they
Yes.
losing ground?
And that's actually what that was my question is, would that work? Would that be reasonable? I think it would. What about the type 2 patients? I don't want to get stuck on the Sarah, but we are talking again about speech difficulties, ambulation and mobility difficulties to consider as a primary outcome.
Well, I think that's one of the measures we could include. We could even, because they're multifactorial difficulties with mobility, sometimes even something simpler like the 6-minute test might be appropriate there. So I think we've got some potential tools there to think about. I think that's a good point. Let's take a break now and start again at 3:15 sharp. Actually, everyone's been doing a great job staying time. Abby, any comments from you?
We will be playing a couple poster presentations during this break if anyone would like to hang around in this room. Otherwise, you're free to go get some coffee.
Thank you very much, Abby. Thank you, everyone.